At the 8th Annual Oncology Practice Summit, Michael Blau, who chairs the healthcare industry team at the law firm of Foley and Lardner, told oncologists how they can ensure their success in the face of healthcare reforms and the shift towards a value-based care model.
Can you speak a little bit about some of the challenges we'll face within community oncology and some of the ways in which we can ensure our stability over time?
Sure. Well, the world is changing around community oncology as we speak. I think as people recognize as a result of government health reform, private market reforms, that the system is going from a volume-based system of fee-for-service to a value-based system which looks like shared savings and payment bundles and episodes of care, and requires changes in the delivery system as well. And so we're seeing the emergence of new organizations like accountable care organizations and primary care medical homes. And oncology, community oncology, has to figure out how it's going to fit within those new paradigms, those changes. And I think in big picture terms, for independent private practice community oncologists to do well in the future, there are a few success factors that one can think about. One is that more likely than not that they're going to have three characteristics. One is some scale, some size, some relevance in the markets in which they are providing services and negotiating. So in order to have the bargaining power to deal with the ACOs, to deal with the insurers, to deal with their local health systems, the larger they can be with the quality players, the better off they're going to probably be. So size or scale is probably one factor. They're probably also going to need to be able to have persuasive bargaining power, so they need to understand their interests and be able to be articulate, intelligent folks who are really able to negotiate effectively for their fair share of the healthcare dollar going forward. But scale and bargaining power are probably not sufficient anymore in this environment. They also have to be able to demonstrate a new value proposition. And so care redesign in oncology to be able to show that you can reduce the oncology spend while maintaining or enhancing quality is going to be enormously important. So I think that combination of scale, good negotiations, but also coupling that with a new value proposition on oncology care will be a powerful market presence to allow independent community oncologists to position themselves for the future.
I know that being able to demonstrate improvements, shared savings, value, will be an important benchmark or important benchmarks as we enter into ACO agreements. Can you talk a little bit about, as physician groups enter into arrangements with ACOs, how you move from fee-for-service to risk sharing when some of those metrics of evaluation aren't clear?
Yeah, I mean, it's a great question. We talk about, it's easy to say, it's hard to do. I mean, we talk about organizations becoming care ready, risk ready, and deal ready. So by care ready, it is the redesign of care. But in redesigning care, I mean, you're going to need new technology systems and new human resources. So you're going to talk about how do we deal with that interface of hospital and physician handoff. To keep patients out of the emergency department, to keep them out of hospital admission. So do we need to extend patient hours? Do we need to have patient navigators? Do we need to have care management systems? What are those new care management systems going to look like? How do we track, measure, and report on their effectiveness? All those are just process measures that are ultimately trying to get at good outcome measures as well to improve the actual care and longevity and health of the patients. So how are we going to do the studies and the research to make sure that these processes are in fact having the impact on outcomes as well? And so your point is absolutely right on the mark, that there are significant investments which are going to need to be made. Independent private practice oncology groups, particularly the small groups, are not going to alone have the resources to do that. They're going to need capital partners to get themselves care ready, and they're going to need capital partners to get themselves risk ready. And by risk ready, I mean to be in a position to bear some of the risk, the financial risk, for the cost and quality of care that they provide. And whether that means that they truly become a risk-bearing organization and have to have insolvency funds and surplus requirements to backstop the risk that they're taking, or whether it just means that they have to be able to track, measure, and report on cost and utilization so that they are able to manage that to profitability in a payment bundle or a fixed budget for oncology care. Either way, again, it's going to require the kind of investments that you were alluding to.
I feel like we need partnership, large capital partners, possibly hospitals that have sophisticated systems of metrics to look at. What do you think in terms of how we get there?
Well, I think you're right. These are easier to do in partnership, particularly where there's infrastructure needs. But the payment system needs to recognize and reward it as well. So if you're going to reduce end-of-life care, and the consequence of that is that you're going to have, as John Brandio experienced and his group experienced, a 12% decrease in oncology chemotherapy drug utilization. That's going to be a direct hit to their compensation bottom line. They're going to have less fee-for-service revenue coming in on their oncology spend than had otherwise been the case. And the payers need to recognize that if there is going to be that much cost savings which is being created, that some of that needs to be shared back with the practices to support their transition to a new value-based cost structure in providing care. So I think it's a combination of partners who can bring infrastructure and a payment system that aligns with value-based care.
One of the concerns I have is when you look at healthcare spend, it continues to increase on a pretty concerning rate. Oncology spend is actually on a different trajectory altogether. And so looking at year-to-year costs, expecting to see continuous decrease is not a tenable goal. And so what benchmark then do you use? Is it these surrogate markers of, chemotherapy utilization in the last 2 weeks of life, hospice utilization in patients of terminal illness? As you've discussed this with payers, what do you think are reasonable benchmarks in terms of cost?
Well, I wish I could say that the payers had sophisticated benchmarks that were oncology specific, but right now the payers are talking about very gross top of the line benchmarks. So they're saying, the rate of growth needs to, in terms of the overall healthcare spend, needs to be modified, needs to be moderated. And so, if you ask them, they say we want there to be a 2 to 3% general cost growth trend. But that is agnostic to any particular specialty, and it's agnostic to oncology. So I think in a gross sense, they're thinking we would like to see no more than a 2 or 3% per year increase in oncology spend. Now that's very difficult because we have new technologies, we have new drugs, which are expensive new drugs coming out in oncology that may be more efficacious, that may be more, in a sense, cost effective and effective for treatment. And they may add more than 2 or 3% a year to the general oncology spend within the broader mix of healthcare service offering. So what the right number is and what the right benchmark is, and I think it becomes even more complicated as we move toward personalized medicine and a lot more molecular and genetic testing.
Which is very expensive.
Which is very expensive, and the drugs, which are almost designer drugs aimed at much smaller populations, which per unit of drug is likely to be also more expensive as a result. To figure out how that factors into a cost growth curve is, I think, a difficult exercise. So I don't think there are good cost growth benchmarks in oncology right now,